Before we go to the slides, I just want to introduce the two panelists. I always like to have a little bit of a discussion on these panels and try to get as much variation in terms of input as possible. Some of the people that I work with at Stanford bring kind of a wealth of some international training. And so the two panelists tonight that I'm going to present cases to, the first one is Dr. Antonio Meola. He's a neurosurgeon, specializes in treatment of brain tumors, among them acoustic neuromas. He did his formal neurosurgery training in Italy. That's why I was joking about my background slide there. And then he did additional training at Harvard, at University of Pittsburgh, where the gamma knife is prevalent. And now he's on the faculty here at Stanford as a clinical assistant professor. And the next panelist is Dr. Maleeha Ahmad. You'll be able to tell by her accent maybe where she's from, but she did her training in neurosurgery at the UK and then did some additional neurosurgery work over in Australia, and then she's also now at Stanford too. So acoustic neuromas, there can be some slight variation around the world in how they're treated. So I always like to bring in some of these international experts to talk. I'm going to first, the process here is I'm going to present some cases to the panelists, and the panelists have not seen these cases before. Let me share my PowerPoint slides. Okay, so the panelists have not seen these cases before, so it'll be a new set of cases for them. And go back to the beginning. And I deliberately don't show them the cases because I want them to think through the process kind of in real time, to have them ask me any appropriate questions that they think are relevant, just to see how the physicians work through kind of the analysis of the cases and ultimately get to their recommendations. And this whole process of working through a recommendation is usually happens behind the scenes. And when you're in the clinic, this is kind of the discussion in the workroom, maybe discussion in the clinic exam room with the patients. But I think it's always good to see this. And there's not a right or wrong answer for a lot of these cases. But I think it's just important to see how the thought process occurs. Antonio and Maleeha, here's your ground rules. I'm going to give you a series of case presentations, and you can ask me any questions you want about if you think you need additional information. And I think for the patients that are a part of the group tonight, if you have some specific questions, there's a way that you can submit questions on the Zoom panel. And what we'll do is we'll save the questions to the end, and then we'll answer them kind of in the order that they've come in. And then following this presentation, as Mark mentioned, there'll be an opportunity after the physicians drop off for just the patients alone to do their own kind of discussion. Okay. So Antonio, Maleeha, you guys ready?
Yep.
Okay. Okay, first case. So this is a 67-year-old gentleman. He complains of hearing loss for several years. He's got tinnitus, which is the ringing in the ear on the right side. Other than that, he feels pretty good. He looks really good for 67. He's very active. He still works, exercises every weekend. His face function is normal. And he had an MRI scan yesterday, which showed something, and he wants you to analyze this. And then he also makes a comment that he had an MRI scan 7 years ago, which he doesn't have anymore, but he tells you it was done for, some migraine headaches, and he was told at that time it was normal. Okay.
Yep.
So this is the scan. Dr. Meola, why don't you tell us what you see here, and tell us how you would manage this patient.
So here I see a small tumor, which is probably a vestibular schwannoma, as expected for the panel. I see basically, where is the arrow, tiny tumor, which is round enhancing, contrast enhancing mass in what we call the internal acoustic canal. Which is, the bony area where the acoustic and facial nerve go. And essentially, yeah, I see this small tumor that is a tumor intracanalicular, we define that. And so, yeah, the management options in this case can be observation, resection, stereotactic radiosurgery. In a case like this, potentially I see two main options. One is observation. The other one is stereotactic radiosurgery. Certainly, in terms of hearing decline, it would be good to know, maybe to send the patient to the ENT specialist and have a hearing test done at the baseline. And then we can have a discussion whether to follow the patient conservatively, like with another scan in, for example, 6 months, or proceed with treatment.
So yeah. let's say you get the hearing test and his hearing is actually almost normal on the right side.
Yeah, at that point, we can have a discussion with the patient and let the patient make this decision, simply because we know that the hearing progressively, if we don't do anything, hearing can progressively decline over time, simply because there is a tumor compressing the fibers of the nerve. So some hearing decline is expected. If we do stereotactic radiosurgery, we expect to basically freeze the tumor size where it is, or even have see that the tumor is shrinking. But on the other hand, there is certainly some dose of radiation that is given to the tumor itself. Depending on the different series, we know that at 5 years, the hearing preservation can be like around 50% for stereotactic radiosurgery. I do not support surgery for a case like this because there is a significant risk to make an injury to the fibers of the vestibular nerve and to the acoustic nerve, and even also to the facial nerve. So yeah, I would have that discussion. If I have to choose, I have to pick one option for the patient, I think that the stereotactic radiosurgery would be an effective option, and I would not wait to see any hearing decline. So okay. I would straight to stereotactic radiosurgery.
Okay, Dr. Ahmad, so for a tumor this size, what would you counsel the patient in terms of success rate of tumor control?
With CyberKnife, we're saying?
Yeah, with radiosurgery. Yeah, it's a pretty small tumor. So well, what would you think kind of the control rates would be for something like this?
Yeah, and I think Antonio kind of touched upon it. So we have such a large variety of series, but generally tumor control rates would be in the high 90s, would be over 90%. And the reason why there's a variation is because of the way people publish tumor control rates and how far out they follow tumors. So what we do know about vestibular schwannomas is that there's a minimum time period of at least 3 years, 36 months that they should be followed. And in Stanford, they're followed for much longer. And most tumors, if they are going to get bigger, and the current guidelines say it's about 75%, so about 3/4 of them will get bigger in the first 2 years. So that's when we have a closer surveillance from a radiological perspective on these. And then once we are kind of over that hump, then we can, increase the time interval between the MR scans. So just to circle back, I'm in agreement with Antonio as well that this would be an ideal candidate for CyberKnife. And I would quote like mid to high 90s for tumor control.
Great. So let's say you got the same scenario. You have the same guy, 67, very, very slight hearing loss and tinnitus, otherwise very active. But instead of that first scan, you have this scan. So describe what you see and tell me if your management plan would change or your recommendations.
Yeah, so who is it?
Sorry. Dr. Ahmad.
Sorry.
I picked on you enough, Antonio. You get a little bit of break.
Okay. Yeah, so this is the kind of case which is pretty like barn door surgical, but my thinking from that is so that we're looking at an axial cut of an MR with contrast. This it's a right-sided vestibular schwannoma. They're known for their kind of like ice cream cone kind of appearance because they open up the internal acoustic canal. There are various gradings that we use in surgery, not to get into too much medical jargon, but one of the ones that we use a lot is the Coos grading, KOOS. And this is a Coos grade 4, which is the largest one, which are generally ones which are over 3 centimeters. That's generally what we call a large vestibular schwannoma. 3 centimeters in like maximum diameter. And also it's compressing upon and causing mass effect on the brainstem that we can see. It's kind of like knuckling into the brainstem. So this is a tumor that needs to be to have a gross total resection and undergo surgery. So from that perspective, just from what we're seeing and the impact on the brainstem is something that would certainly favor in surgery. And I would also want to say that sometimes subjectively we can think that, oh, the hearing's not too bad, but to actually get a baseline audiogram would be quite important in all these cases and in their follow-up as well, just to actually see like what the hearing's like, because we're predominantly that's what we're looking at. We're looking at tumor control. What's the hearing preservation going to be like? And then obviously the facial nerve that controls the muscles of the face.
So Dr. Meola, how would you counsel this patient if they come to you specifically for radiosurgery? And how would you counsel this patient if they come to you specifically requesting observation?
Well, if they come for observation, I have to tell them, of course, that the tumor is large, and this can have several, if left untreated, this can cause several neurological issues. Certainly, there can be a further, there can be hearing decline. There can be facial nerve impairment because of the progressive tumor expansion. And then here the main issue that I see is that the brainstem is shifted, so it's shifted to the left side. So brainstem compression is, sorry, I cannot point where is the brainstem, but basically the brainstem is the part of the brain which is on the left side, exactly on the left side of the tumor. And when we see this kind of compression, certainly there is some risk also of decline of the motor function. So the patient can have weakness of the upper and lower limbs, can start developing imbalance, can develop also issues with coordination, with sensation, and several other deficits of what we call the cranial nerves that are not visible on these slides, but there are other cranial nerves like the facial nerve, like the acoustic nerve, such as, for example, the glossopharyngeal nerve, vagus nerve, that can be compressed as the tumor grows.
So this is
certainly,
yeah, this is the compression that Dr. Meola was talking about. The brainstem is being pushed over by the tumor. Okay, so you basically you gave us kind of the reasons why maybe observation might not be a good idea.
exactly.
If they're asking about radiation, what would your response be?
Well, stereotactic radiosurgery is certainly an option, and it is an option here. The success rate is going to be lower with respect to the previous case, because we know that when the tumor is bigger, the success rate is lower, and both in terms of chances to control the tumor size, as well as in terms of chances to preserve the hearing and prevent further hearing loss.
So what would you quote the success rate for a tumor this size with radiation then?
I think this could be like 85% success rate. Just to say that I could even say 90%. Usually in our series, this kind of tumor went quite well in terms of local control. The only concern that I want to share with the patient is the fact that the dose that will be received by the cochlea and by the cochlea is the area where you know, all the fibers of the acoustic nerve arise from. And so the cochlea will receive a higher dose. So there is a higher chance than with respect to the other small tumor that the patient will develop hearing impairment.
Okay.
And the other things that I have to tell to the patient is the fact that if this tumor swells up because of the radiation, then we should immediately try to give steroids. And if that does not work, we have to do emergent surgery.
Okay, let me ask you guys. So both Dr. Meola and Dr. Ahmad recommended treatment for this patient, 67. At what age would you recommend no treatment? Like 77, 87, 97?
Well,
because I presume at some point, if the patient's extremely elderly, you might, you know, certainly not do the surgery or maybe even not consider the radiation. But what would you? Where's your thought process there?
Well, for surgery, I believe that certainly we have to check what are the other comorbidities. Age per se is, you know, could be a limitation in terms that I wouldn't do surgery above 90-year-old. But I mean, there are no. I don't believe there are reports that support the idea that at 91-year-old a patient cannot receive surgery. for stereotactic radiosurgery, basically we can do that at any age, simply because if the patient does not have any problems with contrast, meaning kidney diseases or anything like that, stereotactic radiosurgery is basically non-invasive at all, so can be received in any patient of any age.
Okay, great. Thanks, guys. So I'm gonna give you this guy's another case. Okay, go back to Dr. Ahmad. So this is a 50-year-old neurosurgeon. So close to my age. So we'd say presents with mild decrease in hearing on the left side. It's got tinnitus. It's got no balance problems, and his facial function is normal. So other than the hearing, he's, seeing patients in clinic, he's operating, and this is what he has. So, the first picture we showed you had a really tiny tumor. The second picture I showed you had a large tumor, and this one's kind of in the middle. And he's 50 years old, and other than the hearing and the tinnitus, in pretty good shape. So what would you, what's your thought process here, and how would you counsel the patient?
Yeah, so here we're looking at an axial MR with a left-sided vestibular schwannoma that's, again, a large one, possibly Acoustic grade 3, possibly 4, again, causing some compression of the brainstem. So I think here we can put the same kind of options to the patient and see what they would want. So one is radiological surveillance, which I wouldn't particularly advise because we know what is happening. However, radiological surveillance, if he wants to go down that pathway, does help us get an idea about the growth rate of the tumor, or any tumor, irrespective of their size. Then we go to, and just to talk about, there's a paper that's come out regarding growth rate of tumors, and they've used machine learning on that. And what they've done in about 700 MRs that they reviewed over like nearly a decade is that they've seen that, so we tend to use like growth rates based on diameters or millimeters, but what they looked at was to actually see the percentage that is of tumors that grow, and in that particular case there is 2/3 of vestibular schwannomas were growing. That means more than 20%, and half of those are growing fast.
Yeah,
so
over what period of time? Over what period of time?
They did a minimum of 3 years.
So over 3 years, 2/3 showed some change in size.
Sorry, I'll just, so over 12 months, 2/3 of the tumor, so they made sure that they had at least 3 years of data, but 2/3 of vestibular schwannomas over a 12-month period showed growth. Half of them were growing fast, and they defined fast as 100% growth, so doubling. And when they went back to see which one of these are growing faster, it was directly related to what the initial size of the tumor was. And the initial size can then be broken down into the kind of grading that we're looking here. So overall, 2/3 of the tumors are going to grow fast, somewhere between, are going to grow 20 to 100%. 2/3 will grow. 1/3 stayed the same. And then there was a tiny sliver, 1%, that grew smaller. So because this gentleman's a neurosurgeon, I would, as like with most patients, we do say, this is the most recent literature regarding growth rate. So you are in the cohort of patients that is most likely to grow faster from what we're seeing. So surveillance would probably not be in his best interest. The next option is then, stereotactic radiosurgery. There is inherently, the number that is now quoted by a lot of the guidelines is that radiation effect, and that means post CyberKnife, you can have up to 40% of an increase in size of the tumor post CyberKnife, up to. So in a tumor that's already big, like the previous one, which is what my thinking was, if there's going to be an increase of up to 40%, then that's the concern when there is, again, an abutting and a knuckling down onto the mass effect, onto the brainstem. So generally, the consensus in our associations and our guidelines is that when it's a large tumor and there is mass effect on a brainstem, probably the best treatment, or one of the treatments, an optimal treatment, would be for surgical treatment. If, however, for whatever reason he's like, no, I want to hold off, then CyberKnife I'm not sure whether we've got like who's great, like high volume tumors and CyberKnife compared, but tumor control rate is pretty is again in the 90s, but it won't be the same like a gross total resection for a large tumor. And for all the reasons that Antonio spoke about, it is important to know that the bigger the tumor, the larger the irradiation of the very critical structures which are around it. And that is why larger tumors have generally been ones that we go for gross total resection.
Okay, so for him, what would your final recommendation be if
I would say gross total resection, and if there is any residual tumor, then CyberKnife could be considered
okay.
for the residual tumor.
Dr. Meola, what would you recommend to this patient?
Exactly the same. Surgery as first option. I would do, usually we do retrosigmoid approach. So which means an approach from behind. And as an alternative, stereotactic radiosurgery could be an option. I just want to remark the fact that we are not discussing radiotherapy, and there is a specific reason for that. Essentially, we prefer stereotactic radiosurgery over radiotherapy because with stereotactic radiosurgery, we can provide a way more accurate treatment to the patient, because we are able to identify the tumor and make sure that the radiation are delivered in a very accurate way, and basically the dose that is received by the structures adjacent to the tumor, like the brainstem, like the cochlea, is minimized. So our radiation delivered by stereotactic radiosurgery is much more conformal to the tumor with respect to radiotherapy. So this is why I'm not bringing up this.
So so if this patient doesn't want surgery, you would treat with radiosurgery?
Yes, I would.
Okay. So this is a real patient, real case. So and he really is a neurosurgeon. So he chose radiosurgery, did well, no facial weakness, had a little bit of further hearing deterioration, and over time the tumor shrunk. Okay. So next case, so Dr. Meola, a 42-year-old woman, she's got some hearing loss on the left side, her facial function is normal, and she was referred to you by a physician who told her that her tumor was a cyst, and she kind of wants you to tell her what that means and what are the implications of that.
Well, when we see a cystic tumor, then certainly we have to make a similar thinking process with respect to the previous case, because also in this case we see some brainstem compression, so surgery could be a good option. The problem of cystic tumors is that there are different data in the literature with respect to the sensitivity to radiation, and they can be also less sensitive at the level of the cystic area. But I mean, there are different reports, and not everybody is in agreement with that. Personally, in a case like this, I believe that surgery could be the best option to immediately decompress the brainstem, and if there is any residual, for example, at the level of the internal acoustic canal, we can always do stereotactic radiosurgery.
Yeah, so the cystic material is the black area. If you remember the tumors that we looked at before when Dr. Ahmad and Dr. Meola talked about them, they were all white. In this tumor, you see some whiteness here, but there's a lot of this black, and that the black is the cyst fluid. So it would be it's technically not solid tumor. It's technically just fluid, Dr. Ahmad, what do cystic acoustic neuromas, do they grow the same speed as solid acoustic neuroma tumors, or is there some how would you tell a patient in terms of how these behave compared to regular solid tumors?
I think they're more variable in their growth rate. So what I said before doesn't quite apply here. We don't see as many vestibular schwannomas with cystic tumors, but they are more variable in their growth rate. And for entirely that reason, I think from what Antonio said about decompressing the cyst surgically is a really good option, because you'd be able to decompress the effect of the tumor on the brainstem. Okay. So they're just more difficult to predict of how quickly or slowly they will grow, and equally so from in terms of their response to stereotactic radiosurgery. It's a little bit variable, and I think there are some differences of opinion amongst neurosurgeons about which whether they would prefer surgery or to continue on with a larger cystic tumor. Like smaller cysts, I think would be more amenable to stereotactic radiosurgery, but a larger cyst like this on a vestibular schwannoma, perhaps more towards surgery.
Yeah, I mean, I think usually what I tell patients is that the cystic acoustic neuromas, as you said, are more variable in terms of their rate in which they can potentially change size. And that's because even if the solid portion of the tumor doesn't change, the cyst could enlarge over time. And so you have a situation where it's not solid tumor that's getting bigger, it's just the fluid pocket, the collection of water generated by the tumor is getting larger, and that can cause increasing pressure. In addition, sometimes the cyst fluid can involute and be absorbed, and so you can have situations where the tumor looks like it got actually smaller, but it may not be that the solid portion of the tumor got smaller. Maybe just there was less fluid around it the next time you did this scan. Okay, let me give you guys some more cases. So Dr. Meola, your turn. So a 26-year-old woman with no symptoms at all. She underwent an MRI scan because a family member has NF2. And so here's the MRI scan. So I want you to explain a couple things, what you see on the scan. Number two, explain what NF2 is to the audience. And number three, explain what you would do in this situation in terms of management.
All right, so here I see an axial scan once again, and here I see enhancement, two small enhancing areas, one in the right acoustic canal and one in the left acoustic canal. And, you know, these are vestibular schwannomas. These are intracanalicular vestibular schwannomas bilaterally. So bilateral vestibular schwannomas are a hallmark of neurofibromatosis type 2, which is a genetic disease characterized exactly by the occurrence of vestibular schwannomas, but not only vestibular schwannomas, there can be also other tumors in these patients, like, for example, meningiomas, neurofibromas. I mean, there can be also other tumors. So here the recommendation is much more difficult, because when we have a tumor only on one side, we can basically afford being aggressive and try to treat the tumor in order to get peace of mind and that's it. When we have bilateral tumors, then the big concern is that if we treat the tumor on one side and, for example, the patient loses hearing, then the patient has only one ear working, and if the tumor grows also on the other side, then the patient can be completely deaf. So here the thinking process, in my opinion, changes, and in a case like this, considering that the patient has no symptoms, I would do audiogram. So in order to check that actually there is no hearing decline, follow up with both the audiogram as well as with another MRI with contrast in 6 months, I would say. And for the moment, so I wouldn't do surgery yet. This is completely different with respect to what I would have done if the tumor was only on one side. On one side, I would do stereotactic radiosurgery immediately. Here, I would do observation.
Okay, Dr. Ahmad, what would you do?
I'll be slightly different here, Antonio. Sorry. I think because this is a 26-year-old and she's got NF2, and these tumors aren't going anywhere, and they're eventually going to get bigger. So there will eventually be symptoms. So I think in this case, these would be cases for discussion about stereotactic radiosurgery, about CyberKnife, because a 26-year-old, we look at an average lifespan, we're looking at, what, 7, 8 more decades of life. And I think somebody who comes in with no symptoms, CyberKnife will have tumor control and hearing preservation, which will be very, very important for a young adult. So here I would say that my recommendation we could try to follow up the growth rate of to see how they're going, as Antonio said, which is perfectly fine. However, I think our aim here should be that somebody who comes in with no symptoms, and we know that CyberKnife has great tumor control rate, and especially for smaller tumors. The smaller the tumor, the better, the higher the percentage we're hitting from tumor control. And we can certainly try to get ensure hearing preservation. So I would say let's try to get CyberKnife to both of these, not in the same setting. We could space it out over a few months across, like do one side and then do the other, or across 1 year and then the second year. But I would, depending on what this person's timeline is and the other family requirements or whatever. So I would say if there are no symptoms in either one, we can ask the patient which one of your asymptomatic vestibular schwannomas would you want us to target first from CyberKnife. Otherwise, radiological surveillance is also perfectly optimal treatment.
Okay, so does having bilateral or acoustic neuromas on both sides give you the diagnosis of NF2?
Yeah.
Okay, so what happens in this situation? I told you there were family members that had NF2, which is a genetic disorder, so it's easy to piece it together. let's say this person, 26-year-old woman, had these bilateral acoustic neuromas, but had no family history of NF2. Then how would you still classify this person as NF2? And if so, how did they get the disease if nobody else in the family has it?
Oh, so NF2 is autosomal dominant. So that generally means you need, somebody in the family to, that's not entirely. So wait, let me call that. So the guidelines are that bilateral vestibular schwannomas is a grade A, like they're A to D grading of neurofibromatosis 2, so type 2. So the bilateral vestibular schwannomas are grade A in terms of the guidelines for NF2. So you can also get sporadic vestibular schwannomas, which are, so all vestibular schwannomas, 90% generally are sporadic in terms of that there is no family history behind it, and then 10% are due to family members. But there is in your clinic you have a program, Dr. Chang, regarding genetic testing in patients, and just seeing whether there are other, because we are looking at, there are other genes that can cause people to have a predisposition, genes and molecular markers to have neurofibromatosis, to have vestibular schwannomas.
Okay. So this is important because NF2 is autosomal dominant. And so the standard way you get it is you inherit it from one of your parents. But you can also be what we call a new mutant, meaning you were the first person you had a mutation in your genes and it turned on the neurofibromatosis type 2 gene. And then now you have it, even though nobody else in the family has it. Okay, so in this case, you guys both, you guys gave a little bit of mixed response in terms of how you would manage it. And I think part of the reason why it's a gray zone is that these are small tumors and the person's not symptomatic. So I'm going to give you a related case. Actually, we'll come to the related case. So Antonio, this is the patient. He's a 72-year-old man. He's got Parkinson's disease. He's got a tremor because of the Parkinson's disease. He's on medications for that. He became increasingly unsteady and could no longer walk without the assistance of a walker. He's got no hearing on the right side. He said he lost that about 5 years ago, and his facial function is normal. Prior to getting unsteady and not being able to walk, he was independent, other than having the mild Parkinson's disease. So he comes to your clinic and he says, my quality of life is very poor right now because, I'm a 72-year-old guy and I already got some early Parkinson's disease. I really want to be able to just, walk around the yard, walk around the park. So what can you do to help me in this situation?
Well, here I see a large tumor consistent with a vestibular schwannoma once again, with some compression on the brainstem. Given the age and the comorbidities, potentially stereotactic radiosurgery could be an option, but certainly the fact that he became unsteady and could not walk could be related to the Parkinson's disease, but could be also related to the fact that this tumor is large and is compressing the brainstem. So here the point is perhaps the bulking of the tumor, so surgery, could relieve the compression of the brainstem, and
Okay.
Uh,
So even though he's 72 and got Parkinson's disease and is
Well,
using walkers a
certainly,
lot.
yeah, certainly there are additional comorbidities, and this is going to impact on their surgical morbidity. If we do something surgical, certainly this is a case that has a higher risk of complication with respect to a 30-year-old man. Here, the surgery is not focused on giving the hearing back to the patient because the patient has no hearing anymore. The only reason why we could do surgery is because I see that there is some serious compression on the brainstem, and because the patient has some difficulties with walking, which could be related to the compression on the brainstem.
You mentioned the word debulking. What does that mean versus?
Well, when I say debulking, I mean surgery. I mean surgery that can be as extensive as possible. So the bulking, let's say gross total resection. So resect as much tumor as possible. And I say that also because a tumor so big can also cause deficits at the level of the lower cranial nerves. So over time, there can be issues also with swallowing and with speech. So there can be other
issues. So you
issues.
recommend surgery. Okay, so this patient kind of, and again, these are all real patients. So this patient agreed with your assessment, Dr. Meola. He wanted a maximum chance of getting his walking back because, again, that was impacting his quality of life. So he underwent a planned debulking of the tumor. And the only reason why I pushed you a little bit on the word term debulking is a lot of surgeons will look at debulking as not the same as a complete resection. It's like, we're debulking, we're going to get the bulk of the tumor out and get the pressure off the brain, but it may not be a complete resection if we're trying to, make the surgical time relatively short given the age of the patient. So this patient had the debulking, had no new problems, facial function is normal, and he was able to walk without a walker 2 months after the surgery. So he was happy with your care, Dr. Meola, your recommendation. Okay, so let's do the next case. So Dr. Ahmad, this is a 26-year-old woman. She had balance problems and hearing loss for the last 4 years. She was seen by a physician 2 years ago when she was 24 years old, and she was diagnosed with a 2-centimeter acoustic neuroma on the right side. And that physician told her, don't worry about this type of tumor because these tumors grow very slowly. So you don't have to worry about things. So she took some comfort with that statement, and she kind of just, figured it was going to be a long time before she ever had to deal with this problem again. But she gradually began to lose her hearing, and now she has some problems swallowing. Okay. So 26-year-old with at least 2 years ago, the tumor was 2 centimeters on the right side. Okay, so tell me what you see and tell me if this explains her symptoms.
Yeah, so we've got the first two are CT scans from the left and the middle, and then we've got the MR on the right.
Let's just talk about the MR. Let's just focus on the MR.
Yeah, quite a large right-sided tumor, which is certainly causing a lot of compression and would fit in with her symptoms, because the larger the tumor, it can start causing compression of not only the 7th and the 8th nerve, but also the lower cranial nerves, which are to do with swallowing, as Antonio referred to.
Yep. Okay. So treatment in this case.
Yeah, I think in terms of her deficits, and especially if there are swallowing issues, where those are quite concerning. all of these options can be placed for, but I think this is this kind of tumor was so large and causing deficits is requires surgical resection.
Okay, Dr. Meola, any differences in opinion there, or?
No, I agree. I mean, here surgery is certainly, you know, but I would say mandatory. Yes.
Okay.
No, I don't have any other.
Yeah, so I think
else to add.
the take-home message here for the audience is that there are some tumors that, based on size and symptoms, there's not really much discussion or options available. There's really, you know, for many acoustic neuroma patients, there's lots of different options available. But for this case, just because of the size of the tumor, there's really only one strategy that you can employ based on the size of the tumor. Okay. So yeah, this patient had a surgical, the same patient that I just showed. So they had a translabyrinthine surgical approach. Patient had some weakness after the surgery, which partially improved, and unsteadiness resolved, and her swallowing issue resolved. Okay, so we showed you that case a couple of slides ago, where the person had NF2, the genetic version of this, and they had bilateral acoustic neuromas that were tiny. So this is another patient. He's 30 years old. His father had NF2, so presumably he inherited it from his father. And he's got bilateral acoustic neuromas. He's got no hearing on the left side, and he's got perfect hearing on the right side. Let's see, Dr. Meola.
Well, here the problem is that something must be done, because there is a severe compression on the brainstem. So the brainstem is really, you know, compressed by these two tumors. So again, here we have the problem that we do not want to make the patient completely deaf. So personally, if we take the left-sided tumor, so if we do surgery on the left side, because I do believe that here surgery is necessary, because the brainstem is compressed, severely compressed. So, or we take the left tumor, or we take the right, or both. Personally, I would take the left, simply because if I take the left, I can decompress the brainstem and certainly not make the right hearing worse.
Okay, Dr. Ahmad, your comments?
Yeah, I agree. I think these are surgical options. I think it's going into the nitty gritty from the surgical side. I do believe that the left side will just be able to perhaps do a translabyrinthine approach, because the hearing preservation is not an issue from the left-hand side, and that's probably, if we need to do a side first, the left side. The right could be done in more of a debulking manner, and perhaps leave a small residual of the tumor inside the canal, which we could then target with stereotactic radiosurgery. That would be perhaps one of the options that I would say.
Okay. Yeah, this is actually, again, a real patient of mine. So what I ended up doing was, as Dr. Meola and Dr. Ahmad both said, you have to decompress the brainstem. The brainstem in this situation is totally squashed here. This person's on the verge of not being able to walk or use their arms or legs because of the pressure on the brainstem. And because the patient had no hearing on the left side, we took out the left tumor surgically, because that allowed us to, get the brainstem decompressed, but not have to worry about losing hearing on that side. The right side, the patient had perfect hearing, but we didn't want the tumor to grow any bigger. So I treated the right side with CyberKnife. So we resected the left tumor, treated the right side with CyberKnife, and did this patient about 8 years ago. And over the last 8 years, we've had no growth in the right tumor and no recurrence in the left tumor. So he's done actually well with this particular strategy. Okay, I want to give you guys, I think, just one more short case, and then we'll go to just some general questions. Okay, Dr. Ahmad, a 60-year-old engineer, he had an MRI scan 1 year ago with a really tiny acoustic neuroma on the right side, and he opted for observation. This guy's he's an engineer, so he's a very smart guy, mathematically oriented, very bright. So now his wife says he's shown some strange behavior for the last several months, and she says it must be his acoustic neuroma. What are your thoughts on that comment? So his behavior includes like being impulsive, having memory issues, yelling at her, losing, forgetting things, losing his keys all the time. A couple times he even got lost when he left the house to walk around the block. But the wife's convinced it's his acoustic neuroma.
So I wouldn't be quick to completely dismiss what the wife is saying, because I know we've talked a lot about brainstem compression, but one of the things that can happen is that what passes through the brainstem is the fourth ventricle, which is all to do with CSF dynamics and cerebrospinal fluid dynamics. So what I'm thinking is that if this was a tumor that did get big very quickly, that grew very quickly, and has compressed the brainstem and then caused compressive obstructive hydrocephalus, that perhaps some of these symptoms could be to do with hydrocephalus. But directly, an acoustic neuroma won't really cause personality changes, okay, because that's kind of different. But if there is any, yeah.
So here's his tumor. It's really tiny there.
Yeah, and there doesn't appear to be any kind of compression on. So
yeah. So this case I just put in for illustration because it. Whenever we do an MRI scan, we look at the entire brain, and we often on this for acoustic neuroma, so if the patient has a known acoustic neuroma, it's kind of just like the wife, we think it might be the acoustic neuroma, but again we look at the whole brain MRI scan, and this time if we look higher up in the brain,
there we are,
we see a different type of tumor, and it's in the frontal lobe, and so this accounts for the patient's kind of memory issues and impulsiveness and things like that. Okay, so I'm going to basically open it up to just questions. So let me go to the question situation. Okay.